Hi everyone. In this video, I'll be going over the mental status exam. Okay, a mental status exam can be thought of as a therapist's version of a physical exam. However, rather than assessing physiological measures like heart rate and temperature, our exam is based on observation and questioning and is looking at mental health symptoms. The mental status exam basically paints a picture of the client's current presentation and is often very useful for diagnostic purposes because it's going to look at all of the elements below. So the components that you see listed here tell you what is assessed in a mental status exam and give you an idea of what we're looking for. You can see that much of this information is observed, meaning that it doesn't require direct questioning. It's something that you are observing just in your regular interaction with the client. Some of this is inquired, meaning that you must intentionally assess for it. So we'll be going over each of these sections, and I do have some videos for certain sections. Okay, first, general description. So I'll be going over the general description section of the DMH MSE and how you would assess for these areas. So on the right here, I have a screenshot of this section of the DMH mental status exam. And this section is relatively straightforward. If done correctly, it should allow the reader to begin to visualize the person physically. And it includes components like age, height, weight, grooming, and so on, some of which are only in the child and adolescent intake, and some of which are also in the adult. We're going to focus in on a few of these next. So first, general description, grooming and hygiene. So here we're looking to see if the client is well groomed and clean when they arrive at the session. This provides you with an indication of their motivation to do self-care and hygiene, as well as their ability to do so. An unkempt appearance may suggest depression or psychosis, so it's useful to take note of. In the case of the individual in this image, he appears well groomed or average, and so that's what I would likely suggest or check off in the checkbox that you'll see here under grooming and hygiene. Eye contact. So we're looking at eye contact. Is the client making eye contact with you during the assessment? You can tell that this is also observed. You're not going to ask about eye contact. But do remember that eye contact should be considered in the context of a client's culture. For some, eye contact is seen as disrespectful, so keep that in mind. In this case, again, looking at the person in the image, there is eye contact. However, his nonverbal language may indicate that he's upset or unhappy to be there or uncomfortable. So for interaction style, which is the next one, I might select something like guarded or suspicious. If so, I would then elaborate by saying something like, the client appeared guarded as evidenced by keeping arms crossed, providing short answers, and hesitating with responses. So this brings me to a helpful reminder. I'll go back here. Obviously, you're checking things off for each section, but you'll notice that they provide a comments section here in each of these different components. So if you're selecting things other than the normal, you absolutely want to include some comments to explain your selection. So in the case of interactional style, I said I would select guarded and suspicious. So you'll see there where it says comments, I would elaborate a little bit further to explain specifically why I picked this or what it is that I'm observing. In the event that you're selecting something that's more of the normal, there's not very much to say in some cases, so it's okay to not have a comment. But comments are always helpful, and it's good practice. Even for like grooming and hygiene, if you're getting well groomed, providing a bit of description would always be helpful. Okay, moving on. Next, we have motor activity. And motor activity isn't exactly asking about behavior. There's a behavior section later. It's actually asking about quantity and quality of movement of the muscles. So it includes things like body posture, general body movement, facial expressions, gait, and level of psychomotor activity. So if you'll see the double arrows down at the bottom here, psychomotor retardation is a general slowing of physical and emotional reactions, and this is common in depression or schizophrenia. So it's going to be on the left side of these arrows. And then at the opposite end, psychomotor agitation, which says agitated here, would be common with anxiety and mania and may be observed as like a fidgeting or a constant need to move, and you would indicate that here. I've also defined a couple of terms here that you might run into in a mental status exam and you might be less familiar with. Okay? And so this These do tend to kind of get overlooked with motor activity, and folks will usually just pick relaxed, normal, calm. But if this isn't actually what the client is presenting with, this is really helpful information, again, for diagnostic purposes. So I have a video that explains or that demonstrates this a little bit better. So I'm going to pause for a second here and take us to that video. Okay, so we'll start here with the psychomotor retardation.
So I've been thinking about calling my daughter, but
So you can see here that the individual is slowed and their reaction time is slower. So now we'll look at another, just a moment. Okay, here we're going to look at catatonic. So here you can see that there's immobility, and this is associated with schizophrenia. We'll look at another now. Okay, in this case, we're going to be looking at the opposite end of that arrow, the opposite end of the continuum, with some restlessness.
I'm not really sure if I want to get a new job. It's kind of scary. I haven't worked for a long time, and last job I had didn't really go that well because I didn't get along with someone.
So you can really see the difference here with the amount of movement, and this individual seems like they just constantly need to be fidgeting and moving. Okay, we'll look at one more. Right, in this last one, we have some agitation. Okay, and it's important to note here that although it's called agitation, we're looking at psychomotor agitation. So you see her movement, her anxiety, kind of makes you anxious looking at it. This is different from like agitation associated with anger, where the person is upset. This has to do with motor movement. Right, so let's return to our PowerPoint here. All right, so that was motor activity, and let's move on. Next, we have speech. This is another observed category, something that you don't have to directly ask about. Some clients will speak a lot, others will say very little. And with speech, we're looking both at what a client says, and we do get into that a little bit more when we get to content, but also at how they're saying it. So things like rate, how quickly is the person speaking? Volume, how loud are they speaking, right? And is it appropriate for that session? Rhythm, does it flow well with appropriately placed inflections? Is it hesitant? And then the content obviously is about what's being said. So we also have some examples of this, so let me pause for just a moment. Okay, so first we're going to look at pressured speech.
So how was your week?
Oh, my week was really stressful. We have this big safety inspection coming up at work, and it's been a lot of pressure, and honestly I've been kind of overwhelmed because we have to audit all of our files, and we have to check all the machines to make sure that they're working and make sure everybody's training is up to date, and not everybody's trained, and frankly some of these...
Okay, so here you can see that the rate of speech is very rapid, and there isn't a lot of space for the therapist to interrupt because the speech just goes, the rhythm of speech just continues and continues. There aren't appropriate inflections that would allow, there aren't appropriate moments of breath or break that would allow the therapist to interrupt. Next, we'll look at another. Okay, so here we're going to look at laconic speech.
So tell me how your week's been.
That's alright.
What'd you get up to?
Just the usual.
And you had mentioned last week that you were expecting some stress at your job. How did that go?
It was okay.
All right, so here we have really brief responses. There isn't a lot of elaboration. It's almost like you feel like you're pulling teeth to get any information from the client. This is sometimes called poverty of speech. And we'll look at one more. All right, here we're going to look at echolalia, which is the repetition or the echoing of a question that's used instead of answering the question.
So what would you like to talk about today?
So what would you like to talk about today?
I was thinking maybe we could talk about how your week's been.
How your week's been?
Okay, so there is an example there. And do note that these videos are available on YouTube and they're very helpful. They also have guided practice, so feel free to use the links in the PowerPoint if you'd like to see more of them. Okay, so that was speech, and now we're going to move into orientation and serial sevens. So here we're trying to see if the person is oriented to their current circumstances, and this information is inquired as opposed to observed, so you do need to ask about it. It's sometimes referred to as oriented times 4, and we're looking at person, so does the person know who they are, place, where they are, time, the date usually, and situation, so the situation they're in, i.e. that they're in therapy with you. And you would just ask those questions. Serial sevens is a related concept. It's a little bit later in the mental status exam, but it feels appropriate to include here as we're going over it. So this is used to assess for dementia, check memory, and check concentration. And you would essentially instruct the client to count down from 100 by 7, so 100, 93, 86, and so on. And yes, I had to prepare those numbers in advance of this lecture because it's not actually that easy to do. Okay. Next is intellectual functioning, and this is just basically looking at general knowledge, such as knowing who the president is, and you rank it as below average, average, or above average, and it is inquired. Okay, the clock drawing test is an interesting one and can be helpful to screen for cognitive impairment, dementia, and spatial dysfunction. You provide the client with a piece of paper and you instruct them to draw a clock. There are a couple of different methods of doing it. So in the free draw method, for example, they draw the clock fully from memory, or the pre-drawn method, you draw the circle and then they fill in the time and the numbers. Either way, you would score it by counting how many errors were made, and a normal score is between 0 and 3 and indicates no cognitive impairment. So this is something you can also do as part of your mental status exam. Next, we look at memory, and this is the last part of the general description section of the MSE. If it's unimpaired, indicate so. If it's impaired, indicate which part of their memory is impaired. So immediate memory would be here and now, and you could check that by asking the client to repeat 6 digits forward and backward. Recent memory is also known as short-term memory and could be assessed by asking the client to tell you what they had for breakfast, for example. And then remote is long-term memory, and you could check this by asking the client information about their childhood. Okay, the next section of the MSE is mood and affect. So mood is the client's internal subjective emotional state, and this is one of the few elements of the MSE that relies on client self-report, since we're basically asking the client to report their mood over the past few weeks. So how have you been feeling for the past few weeks? Simple enough. And there are some terms defined for you in case you're unfamiliar with what those are. Affect is different from mood. This is your objective observation of the client's expressed emotional state. So how do they look? What feeling are they expressing in their appearance or in their attitude? And this is often determined by facial expression and interactions with you. So somebody who looks sad, right? Or someone who looks happy or scary, or someone who's angry, you would get that based off of looking at them. Okay, next we'll move into perceptual disturbance. And perceptual disturbances are false perceptions, which may be caused by physical or mental disorders as well as substances. And in the mental status exam, we're looking specifically at hallucinations and self-perception. So I'll go over those next. Hallucinations, first, are false sensory experiences, and they can occur in any of the senses, as you can see here. So visual would be seeing things, olfactory, smelling things that aren't real, tactile is touching things that aren't actually there, auditory would be hearing things that aren't actually there. And you could assess these with things like, do you ever see things that upset you? Do you ever feel things that aren't really there? Do you ever hear things that aren't really there? Have you ever had any strange sensations in your body that others don't seem to have, and so on? Two other unique types of hallucinations that we're looking for in the MSE are command hallucinations, where clients feel that they're being given instructions to do something, like God is telling me to step in front of traffic, something like that. And then persecutory, where clients feel that someone or something is wanting to harm them. So feeling that they're being followed, that someone's going to, attack them in their sleep, things like that. Okay, next we have self-perceptions. And here we're looking at depersonalization, derealization, and ideas of reference. So depersonalization involves the feeling of observing yourself from outside your body and having no control over what you're doing. So it's sometimes described as feeling as though you're floating in the air above yourself. And this is common in certain psychotic disorders. Derealization involves feeling that the things around you are not real. So feeling emotionally disconnected from people that you know and care about, for example, feeling as though you were separated from a glass wall, or by a glass wall, excuse me. It can also include distortions in perception of time. Okay. And then ideas of reference involve inaccurate interpretations of events. So feeling that some kind of neutral thing has special or unique significance to you. So an example would be like believing that a radio show host is broadcasting a special message just for you. That would be an idea of reference. Okay, now with thought process disturbances, we're looking at how a person makes sense of the world and makes connections between ideas or information. So first we have associations. Associations are essentially how people link things or ideas together. And you can see in the arrow here that we go from unimpaired, meaning your associations make sense. So things are linked, like talking about loneliness when asked about your depression. That makes logical sense. Those things are associated. Then as things get more and more disconnected, we move toward word salad, where the ideas just have no connection whatsoever. So I think the video demonstration is especially helpful here. So we'll move to that next. Okay, so first we'll look at circumstantial, which involves some unnecessary digressions.
Well, I guess I should tell you how I got fired from my job last week. You know, I went in last Monday, and you know, when I first came in, I saw my friend Luann sitting there, and just she had this kind of like daydreamy look on her face that she gets when she's like totally like not paying attention to her work. And you know, we go back quite a ways, but anyway, so like we had some like filing to do that morning, so we went back in the file room and we were kind of taking our time. And
okay, so you can see here that the ideas that are being shared have some link to them. They kind of are connected, but they feel a bit rambling, and so the person isn't really getting to the point. They're kind of just going from mildly connected idea to mildly connected idea. So let's look at another. Okay, here we're going to be looking at tangential, and you'll notice that the digressions become a lot more noticeable. So let's look.
An example.
So, like I said, I was really hoping to hear from my daughter. I haven't heard from her in over a year, and I was going to call her on the cell phone. I have AT&T, and actually, you know, I've not really been very happy with AT&T, and I was thinking about calling AT&T and really getting into some conversation with them about what kind of plans I could do, because I've heard there's a lot of different plans out there that might be.
Okay, so you'll notice here, he started off talking about his daughter, and then this cell phone idea totally made him shift, pivot to a different direction. He lost sight of what the point was that he was talking about, and now he's talking about something completely different. That's tangential. Let's look at another. Okay, here we're going to look at loose associations, sometimes called rabbit holing.
Like I said, I lost my job. They caught me drinking on shift, and I could go for a drink right now. I think my favorite drink is probably scotch. I drink it a lot. I usually have a couple of drinks when I go home. I go home and then I watch Late Night with Jimmy Fallon.
Okay, so there you see he went into the rabbit hole talking about drinking, and then that took him to another one. We'll look at one more. Okay, and in this last one, we're going to look at flight of ideas.
Yeah, I was thinking about my mom was always a little weird like that. I'm not really sure what she always, I don't know, you know, that's what I was thinking about that the other day, because she was in the kitchen this one day and she was looking out the window, and there were all these little red glass vases, which is, you know, I really need to get a car. If I had a car, I'd be able to make it easier to, I'd be able to make it to counseling, and, you know, and that's another thing too. I was actually thinking about asking you a question about something. I wasn't really sure whether or not I should talk to you about it. I don't know. Sometimes I feel.
Okay, so here, there's just lots of different thoughts, ideas that are just coming up, and their linkage is minuscule if there at all. And so that is flight of ideas. Now let's move back to the PowerPoint. Okay, so that was associations, and now we'll move into concentration. Sorry for the blur there. With concentration, we're assessing this directly by asking the client some questions. Usually it's assessed by asking a client to spell a word forward and backward and seeing if they can do so. It can also be assessed through observation. So has the client been able to focus and concentrate during the session? Do they seem distracted often? Do you find yourself having to repeat questions often? Are they ruminating, meaning that they're focusing excessively on one thought or event? With thought blocking, we're looking at someone who loses their train of thought suddenly. And then with clouding of consciousness, it's another way of saying like brain fog or mental fog, where the client has a hard time paying attention and focusing. And so you'd indicate that, and if it's anything other than intact, you would definitely add a comment. And even if it's intact, you could explain how you assess that. That would be helpful. Okay, next, abstractions. And here we're looking at how the client thinks. Are they very concrete in their thought process, or are they able to abstract concepts? And you can assess this by asking how items are similar. So for example, how are an apple and an orange similar? And you'd expect them to say things like they're round or they're fruit. Right? You could also check to see if the client understands certain proverbs, if they make sense to them. So you could ask, how would you describe the meaning of the saying, 2 heads are better than 1, and seeing if what they come up with makes sense. Okay? And you would indicate intact or concrete. With judgment, we're looking at the client's ability to make good decisions. And you could assess this with hypothetical questions, like what would you do if someone insulted you on the street? Or since you're probably quite a bit along in the assessment at this point, you could pull something from their own life experience and assess their judgment that way. Like if you've got like a really depressed client, you could say, you know, what would you do if you were feeling really lonely at home, and see what they say. With insight, this involves awareness and understanding of one's illness or one's symptoms and their need for treatment. Clients with schizophrenia, for example, tend to be unaware of their mental illness, and we would indicate whether their insight is intact or impaired. And this is a judgment that you're making based on how the client has presented and how they've described their problem and the things that have contributed to it. Okay, thought content disturbance involves what the client is thinking and also includes the presence or absence of delusional or obsessive thinking. If any of these are present, you definitely want to provide details regarding the intensity and the specificity of these particular disturbances. So first we have delusions, and delusions are false beliefs that a client continues to hold despite having evidence against those beliefs. There are several different types, which you likely learned about or will learn about in psychopathology, but I'll go over just a couple. So persecutory, for example, involves believing that you're being mistreated or that someone is spying on you or planning to harm you. Grandiose delusions involve an overinflated sense of self-worth, power, knowledge, or identity, like I'm the smartest person in the world, and actually believing it. Somatic involves the belief that you have some kind of physical defect or medical problem, even though you've gone to the doctor and there's nothing wrong with you. And you can look at the rest of these in your DSM, but these are delusions. If any of them are present, you would indicate so. You would describe a little bit more detail about the particular delusion and how intense it is. Some questions to ask when you're assessing here. Do you think people are stealing from you? Do you feel like you're a bad person? Do you feel guilty as though you committed a crime? Do you think you have special powers? And so on. Next are ideations, which are basically ideas or content of thoughts. You can see here that there are several different kinds. Many of them are self-explanatory. So phobias would be irrational fears that the client's describing. Obsessions involve intrusive recurring thoughts. Bizarre ideations are those that involve things that are unusual and not derived from ordinary life situations. Like I keep feeling like I have a duck on my head. That would be a bizarre ideation. Okay, now we're moving into behavior. Remember, we did motor activities, so now this is actual behavior. As you can see here, these are pretty self-explanatory and have to do with the client's behavior in the session with you, as well as their behavior in general. So a client may be very compliant and appropriate and cooperated in session with you, but they may describe, or you may know from a different source, that they're very aggressive in their daily life, or that they are manipulative in their daily life. And so you would indicate both of those and describe them in the comments. Okay? At the very minimum, we want to indicate in the comments where and when these behaviors happen. Are they happening in session, outside of session, what are the specific circumstances, and so on. Sorry, really quickly back here, if you have a client who's coming to you because of like an oppositional defiant disorder or ADHD or something like that, you're going to want to pay attention to this particular section even more so and provide some detail. Of course, you're going to have more detail in other parts of the assessment, but you want there to be consistency throughout your assessment, and that includes making note of those disturbances here. Okay, next we're moving to suicide and homicide. So with suicidality, we are trying to assess, does the client have any ideations or intents to harm themselves? I have some questions for you that could lead that assessment. There is a suicide assessment component in the DMH assessment that we'll go over in much more depth later in the course when we do assessing safety. But just in case, here are some, and then here are some for homicidality. Also note, if you've already assessed this with your client in a different part of your assessment, like it came up in the presenting problem, for example, and you fully assessed at that point, you wouldn't ask them all over again, because then it seems like you weren't paying attention. You would just move that information in here, or if you did want more detail, you could ask for more detail and get it. But you do want to make an indication here about suicidality and homicidality, even if you have already assessed it elsewhere. Okay, other. This is the last section of the MSC, and these are just observed categories that you would only check off if relevant for this client. So if these things aren't relevant, this is one of the few places where you don't have to actually mark something off unless it is true for this client. But what I would encourage you to do is, if you have nothing in passive or in other, in the comments, you can write something like, does not apply to client at this time, or not observed in client at this time. Again, just to show that you actually assessed for this and not that you just overlooked it. Okay, so if these apply, check them off, add comments. If they don't, at least add a comment that says, does not apply for this client at this time, or something of that sort. Okay, all right. So that's it for the entirety of the MSE, the mental status exam. Please do take a look at those videos if you're wanting more examples or you want to look at them again. There are also other videos for other parts of the mental status exam on that same channel, and I highly recommend them. If you have questions, please reach out and let me know. And otherwise, I will see you later. Thanks for listening.